I'm going to get Dr. Babin Seva and Dr. Tatiana to just introduce themselves. This looks like a joint kind of a presentation. And then after that, please feel free to introduce us to the case.
Thank you. I'm Babin Seva Anastasia. I'm a Ukrainian neonatologist. I work in Ukrainian city, not big, but a very nice city, Chernivtsi. It's a city next Romanian border. I'm a professor of our Bukovinian State Medical University, and also I'm a practical doctor, practical neonatologist. I work in intensive care unit in our maternity hospital, and also I'm a consultant of our perinatal center. I'm a neonatologist, I'm a pediatric anesthesiologist and specialist from ultrasound. We have, in our country, we have a special specialization from ultrasound. I have maybe more than 25 practical experience from neonatal practice, and maybe 2.5 years from ultrasonography in neonates, maybe 5 or 6 months. It's a intensive work, intensive job with pulmonary lung ultrasound. And it's a goal, it's a scientific STEM for me, and I try to write some scientific work about lung ultrasound, maybe not only about lung ultrasound, but combination plus neurosonography plus echocardiography also.
Amazing. That's
amazing. Information about me.
It's an honor to have you with us. Please crack on. We can do the presentation. Go for it. Could I present my presentation? Yes, please go ahead. Please go ahead. Okay. It's case about child, about newborn with bronchopulmonary dysplasia. It's a baby from first pregnancy and first delivery. Mom is very young lady, 16 years old. It was a cesarean section because it was placental abruption. Unfortunately, we didn't have a time for antenatal corticosteroid from prevention of RDS, and a very small male was born. Gestational age 30 weeks. The weight 800 grams. Apgar score 347, and we started to use NCPOF in delivery room. But unfortunately, next step, it was we continue nasal CPAP and CPAP, but this newborn needed Curasurf, the first dose, 200 milligrams per kilo by LISA method, but finally we should do intubation and continue invasive mechanical ventilation and repeat next dose of Curasurf, 100 milligrams per kilo. And unfortunately, this baby needed invasive mechanical ventilation during 18 days. And also, unfortunately, but she had pneumonia, intraventricular hemorrhage through three states, PDA, and necrotizing enterocolitis.
current status when I did a lung ultrasound. He has 38 weeks. Postmenstrual age, the weight 1 kilo 800 gram. The main diagnosis was BPD, bronchopulmonary dysplasia, and you can see a result of X-ray. Yeah? Also, we couldn't exclude hemodynamical scientific significant PDA, lung hypertension. The mean pressure in lung arteria was 32, 35. At this moment, this baby has respiratory problems and Downer score 2-3 stage. And at this moment, this baby needs oxygen therapy. Sometimes they need 100% of oxygen. I did lung ultrasound. I use only 4 areas.
So, Bhavinseva, just to ask, so just which machine are you using?
I use handle probe. I have only, unfortunately.
Yeah, no, handle probe is great.
It's like a butterfly.
Sure.
Very nice.
And which machine is it? Don't worry, it's okay. Absolutely fine. So, do you know the frequency on your probe?
9.
9. Amazing. Lovely. Please carry on. Yeah.
And I used I exam only 4 areas. I unit 1, 2, and 4, 5 without posterior line.
No problems at all.
And I try to. It's very short video, but it's right 1 plus 2.
Lovely.
And I think that we can see a very nice pleural line. We can see a very nice sliding. We can see R lines. These are lines. But also simultaneously we can see B lines and more than 3 B lines. So maybe it's a pathological number of B lines. And I'm not sure it's very clear, but I can see a lung consolidation also, especially on this area.
Yes.
But on this area, no.
So
I hope.
Yeah, no, definitely over there.
You can see also.
Yep.
This is left 1, 2. Also more long video, and also we can see a nice pleural line, nice sliding. We can see our lines also, but maybe not so nice lines. Also B lines more than 3, and lung consolidation, it's more more, как сказать, Татьяна?
No. So that's beautiful.
On these areas.
So very good, fantastic. So we're just going to go back to those images, Dr. Bhavinseva. So what I'd like you to do is I just want you to play R1 too, just so that everybody can see it. So what you can see is you've got, and this is, if we go by structure, you've got a batwing sign, you've got 2 ribs. Can you see my marker at the moment? Are you able to see my marker? Is everybody able to see?
No,
Not
we
yet,
can see.
sorry.
No.
Okay. So now can you see my marker?
Yeah, we can see it.
Now, yeah.
Yeah.
So basically what you're seeing is classically the ribs. You basically, possibly because your probe's a little bit oblique, you're getting the acoustic shadows over here. And then you have the kind of pleura, which is your batwing sign. Now, I basically would encourage all of you, and you've done a beautiful presentation, to go by structure. So the first thing that you must always identify is that you've got a batwing sign. And with the batwing sign, really, if you just click the image again, the next thing you're looking at is the pleura, and you've got continuous pleura. It's really nicely delineated, beautifully. Now, you can see the superficial area of the lung very well, but the deeper area of the lung is where you're getting a very large area of dropout. And the frequency you're using is 8. Now, your machine has 2 areas of focus. So you have one area of focus, which is beautiful, which is at the pleural line. But that second area of focus, you might want to keep a little bit deeper so that you get better delineation of the deeper lung. Now, because this is an 1800 gram baby, my first kind of feedback would be that 4 centimeters should be more than sufficient, because if you go in the front, laterally and posteriorly, 4 centimeters will cover most of the lung in 3 dimensions when you do R1, R2, R3, R4. I mean, we're not going to do R5, R6. So what I'd say is few things. You've got a beautiful batwing sign. Your probe is definitely very well positioned because your pleura is roughly parallel and it has good contact. And with that, the superficial area is very well demarcated. Again, you're absolutely right. There are B lines visible. Now, by definition, B lines should reach the bottom of the lung field. Now, you're right, they are B lines, but the reason they're probably not reaching the bottom of the lung field is because you're getting dropout over here because your focus could be lower. The other option is, if you were using a higher frequency, is to drop the frequency a little bit, but you're already on a frequency of 9, I think you said, which would probably be low enough. You could go down to 8 and see if you get a little bit more depth. I don't think
we've got any guidance about how to perform the saline irrigation and
sorry guys, can I just mute a few people? My apologies. Yeah, sorry. So very nice image. Now, just going back to consolidation. So this area over here, if you just want to play it, if you play your
next video or this video?
This video.
Unfortunately, this video.
I've messed it up really badly. So can you see this area over here that highlights, that takes its origin from the pleura? That is a consolidation. Just remember, deeper consolidations, you have to be very careful because they must always originate from the pleural line. But yeah, this is a very good image. So now we can go to L1 too. So you can just play it. So again, the pleura is thick, definitely more than 5 millimeters blurred, and you have a lot of B lines that originate from it, which break the A lines. Again, just similar comments. You could reduce your depth, put your focus down, and that'll probably give you a slightly better image. But in terms of me being able to make an interpretation, this is good. Absolutely. My main worry with clinical correlation in the history is that pleura is thick and blurred. You definitely have some subpleural consolidations. One over here that is really worrying. So if you could,
this area,
yeah. Now this area is one I wanted to kind of mention. I can't see origin from the pleural line. So by definition, we should see origin from the pleural line for us to definitely say it's a consolidation. My gut feeling is it probably is a consolidation. And if you were to interrogate a little bit more, you'd probably get, like if we were a little bit lower, you might find that the pleura there is slightly more involved. But by definition, I can't call this a consolidation. What I can call a consolidation is this area here. Can you see this area here? That is definitely, and again, I really worry about this area over here in terms of you have a B line with maybe a comet tail, but it's quite a regular pleura. For me, the pleura is quite blurred, quite irregular. So, but nice images, very good. So carry on, please. The floor is yours again. Sorry for messing your images up.
Thank you. Так, ой, maybe you can clean my
okay.
area.
Yeah, let's try and do that. Lovely. Yep. Carry
Thank
on.
you.
Yeah.
Right, 3-4.
Very nice image. Yeah, beautiful. This is beautiful. Please carry on. Yeah, please describe it. Yeah.
No, we can see again plural line, да, but maybe no, I think it's a technical mistakes, да. It's not a real destruction of plural.
Maybe this is artifact, yeah.
Yes, да.
Of ribs. Or,
That's beautiful. You're absolutely right. You've got acoustic shadow coming there. So, yep. Well, I agree. Carry on, please. Yep.
No, again, we can see a sliding. We can see R lines.
Yep. Beautiful.
R lines, B lines again more than 3. And about lung consolidation, maybe yes. I'm not sure on this area, no? What do you think?
Do you want to play it again, just?
So, on this area, no?
This area here, and yeah, you're right. This area here, quite suspicious. So, yep. There you can see, just for me, it's a little bit more dense than I would like. Yep, you're right. Yep, beautiful.
And left 3-4.
Yep. Yep. Very nice. Yep.
No, similar, maybe similar points. Plural line okay, sliding okay, R lines okay, B lines more than 3, and lung consolidation, yes. Not this
There.
area, this area.
Yep. Maybe here as well. Yep. Very nice. These images are very nice. Again, good depth. A little bit of dropout in the regions behind the acoustic shadows, which you normally get, but these are really nice images. I would struggle to get better myself. So well done. So, I mean, looking at this kind of presentation and clinical correlation, what do you think might be the problem?
No, I think it's a typical BPD for these babies now without antenatal corticosteroid prophylaxis with I'm sorry, with pneumonia, now with infection, and a very long time for invasive mechanical ventilation. But we have a positive point because today we checked and we repeated the echocardiography for these babies, and it's the pressure in lung artery is less, 25, 22, and it's positive for these babies.
And I mean, in terms of respiratory signs, does the baby have much respiratory distress, or is he relatively comfortable?
Yes.
Okay. That's amazing. I think I mean, food for thought for the group, guys. If you haven't put a probe on, it's really a good opportunity for you to put a probe on, because you can see how easy it is to get the anterolateral areas. And I mean, it's, these are lovely images where you can make out the artifact nicely enough to make clinical interpretation of the baby's lungs. So my compliments and thank you. It's something that we all learn from. Tatiana, do you have anything to add? You both come with a wealth of experience. So
no, presentation is very good to my mind, and thank you so much for all. You can clearly see how change lungs and how treatment is useful for these lungs, and how develop lungs instead treatment.
Beautiful. Just a few things for the audience again. So what are the benefits of being able to do lung ultrasound in this group of babies? Now, I think what is quite crucial, and we'll be covering this in the latter part of the course. At the moment, we're just giving you a flavor of how peer review is done, but heart-lung interaction is quite crucial in babies after the first few weeks of life, because there are multiple things that might be making respiratory distress worse and contributing to chronic lung disease. Now, there's the respiratory component of invasive mechanical ventilation and infection, which is causing damage to the lungs. There's an element of volutrauma that's happened, atelectotrauma. But what might also be contributing to this is a duct which is causing left to right shunt. Now, there are very good papers now that are available that have just been presented at the International Lung Ultrasound meeting by Al Medina, and Al Medina will be presenting on this, where you can quantify profile. And really, if I've got a predominantly, I would say, B profile, which is what you have here. This is predominantly a B profile with occasional A lines, with lots of subpleural consolidations and or atelectasis. And I'm going to show you some images today which represent atelectasis. Then your CO2s are high, you've got a high oxygen requirement. The element there might be lung recruitment that is needed, which might mean that you want to go up on your non-invasive ventilation. That might mean you're going from CPAP to DOPAP or BiPAP, or you're just going up on the PEEP to recruit. And you can use serial lung ultrasound. And I'm going to show you a case that we have today where we kind of can use it to recruit lungs and see how atelectasis recruits. On the other hand, if this profile in this set of baby kind of shows a dominant B profile with a whiteout lung, but very few subpleural consolidations, in the presence of a kind of an echo that shows a large duct, that's a left to right shunt causing that B profile. And I might elect there to go on to diuretics as opposed to wanting to increase ventilatory support. And my follow-up in that situation would be after starting diuretics is a follow-up scan day 2, day 3. And if I can then convert this B wet profile to well-aerated A profile, again, I'm going to show you images of that, then you know that your diuretics have worked. So again, in terms of kind of therapeutic efficacy, you can use lung ultrasound serially in this situation. The radiation exposure, the duration with which you're going to do the scan, 90 seconds to get all these views, is going to be much less than having to do serial x-rays every day to kind of see whether your diuretics have worked. I mean, some people would argue you can see clinical improvement, and if the FiO2 is coming down, you're winning. And I'm completely accepting of that. But actually, if you can see that happening at the level of the lung, then that is also quite reassuring. Thank you so much for your images. I was just wondering, is Ashraf here by any chance? Because Ashraf was going to share images today.
Would I stop my demonstration? Yes?
Yes, please. I'd be so grateful. Is there anybody else who has any images that they might want to share? Okay. Any questions about that presentation? It's a beautiful presentation from Babin Sir.
I have some images. I can share it.
Okay, Fuad, go for it.
Yes, but how can I share it? I couldn't upload it to the Dropbox. Could I send it to your
So have you got the
WhatsApp?
the PowerPoint on your screen?
Yes.
So just open the PowerPoint.
1 minute.
No problems.
Yeah, I open it now.
Okay. Now I want you to go to the green button, share screen at the bottom.
Share screen.
Yeah.
Yeah.
And click on it, and you will see your PowerPoint presentation.
Yeah, I shared it.
Well done. Well done. So we can go to your first slide.
Yeah, so yeah.
And we'll just go to full slide mode. Can everybody see that?
Yes.
Amazing.
Yes, we can see.
Amazing. Thank you. Go for it, Fuad. Well done.
Could you hear me, right?
We can hear you. You're audible and visible.
Yeah, so yeah, sorry for that. I don't know how to, yeah.
So we can see your slide. Go for it.
Yes, okay. So I'm trying to work. I don't know if my camera is working now.
Your camera is working. You're also visible. So you're visible and audible. Go for it.
Yeah. So this is preterm baby 33 plus 6 D2 of life transferred to our level 3 units from level 2 after intubation due to deterioration of his respiratory status. The baby was born by Cat 3 cesarean section. He was born in good condition, no risk factor of sepsis. Mom has fatty liver. And the baby has two CureSurf. The first one, 200 milligram, and second was 100 milligram before the transfer to our side. I was on call and I received this baby. I did the lung ultrasound and it was before the chest X-ray. And I used the L10 to 22 linear probe.
And which machine, please?
You know, I'm not sure. It is Philips. I'm not sure about the machine.
Sure. So guys, when you're presenting, it would just be nice to know which machines you have, because in terms of helping you with image optimization, what I would like all of you to do, for those of you who want to kind of have peer review, is take a picture of your board. I'm going to show you how to do it today so that you can send it to me. And that just means that I might be able to help you with image optimization. So by all means, go ahead, please.
Okay, yeah. So this is the a capture from the screen. I couldn't download
That's
this.
all right. Perfect.
Yeah. So the uppers are the right side and the lower are the left, and the start from the left of the screen is R1, then R2, then R3. The R3 is the lateral view. The lower is the left side of the chest. It is L1, L2, L3 from left to right. Could you see the? Yeah.
We can see them. Yeah.
Yeah. So the R1, the pleura looks thick but sliding. There is compact P lines. There is no E lines in this in the R1.
Yep.
In the R2 also there is pleura is sliding, and there is comet tail. There is subpleuric consolidation. Also, pleura is thick. Awesome.
Don't worry, it's okay. Well done.
Yes,
well done.
and there is compact P lines. Also, there is no A lines.
Yeah.
In R3, the pleura is more. It is. I think it is more thin and regular than the R1 and 2. But also there is compact P lines. There is no A lines in this one.
Yep.
The left 1, 2, and 3. The pleura is more thicker than the right side, and there is significant subpleuric consolidation. There is no E lines in the three views, and there is compact P lines. So my gut feeling at that point that this patient has a picture of RDS. It is more severe on the left than right.
Okay, well done. Yeah, I would agree with that. So just for the audience, what we're going to do is, again, I want to give you a structure for how you describe your scans. Fuad, you've done an absolutely brilliant job. So first of all, what is very important is go by protocol. Protocol says we identify the batwing sign. So I can certainly see, and I'm just going to take my cursor again, and I'm not going to mess your screen up if I can. So there's the rib that you can see, at least one rib. Certainly here I can see two ribs and an intercostal space. So that in essence is kind of your batwing sign. Now, because you're using a linear probe, what you have is you've got a good footprint. But even with this footprint at the moment, what I'd like is I need you to get ideally where possible, all of you should be trying to aim to get 3 ribs and 2 intercostal spaces. And you just about have them over here, because that for our image optimization is the ideal level, 2 intercostal spaces each. If you have a long linear probe, as I will show you today, I have a very long linear probe. It gives you hold ribs, and you can really do L1 and L2 in very small babies together. So the first step, the first kind of step-by-step process is the batwing sign. You've kind of got that. You definitely have a batwing over here, beautifully demonstrated with the pleura in between. Just going to get my rubber and rub things out so that we don't mess everything up. Now, that's step one. The second step after the batwing sign is identified is defining pleura. And you've described it very nicely. So in terms of kind of your pleural line, you've got pleural line over here, which looks very blurred virtually throughout, except here where it's thin, it's very well delineated. But just underneath that, you've got these small areas of subpleural consolidation. And what I'd say is that this becomes more prominent as you go on the left. Basically, what you've got over here is what is classically subpleural consolidations with what is described as a snowflake sign. And when we do RDS, we'll talk about the grades of classification of subpleural consolidations for diagnosis of RDS. I mean, the subpleural consolidations are very well visible over here on the left side. So I think I would completely agree with you that the left side is worse. Now, for the diagnosis of RDS and differentiation from TTN, the presence of subpleural consolidations has a very high sensitivity and specificity in differentiating the two. But other markers that this is RDS as opposed to TTN is in TTN, we know that there is aerated lung and non-aerated lung. And don't worry, we're going to cover all of this. So you have spared areas, areas that look well aerated with A lines, versus areas that are not so well aerated. And I mean, here we've seen anterolateral scans, and actually it's uniform diffuse white. It's just white, 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 white. You basically have alveolar interstitial syndrome. And, looking at all of this, for me, subpleural consolidations, a uniform appearance, no lung sparing, clinical correlation. Was this a 33-weeker who had steroids, Fuad? Do we know?
Yeah, this mom has a full course of steroid.
She's had, okay. And I'm just curious, I mean, a 33-weeker with this kind of clinical presentation nearing intubation, it's a little bit unusual. So my only other question at this particular point is there any history of sepsis?
No history of sepsis. Mom has only fatty liver. His ALT was very high, was 800. And this baby has an incident also, initially he required the low pressure, 14/5. But when they are transferring the patient from the incubator to the Embrace or the transferring team incubator, the baby developed his oxygen requirement increased and the pressure increased to 25/5.
Okay.
The delayed aborted the transfer for a while, did an X-ray to rule out the pneumothorax. There was no significant pneumothorax, but the only explanation for that, this patient disconnected from the ventilation during the transfer from the incubator to the transfer team. So it might be loss of recruitment.
Can I ask, was this lung ultrasound done after that?
Yes, I did this
Okay.
lung ultrasound maybe 4 or 5 hours after that. Once the baby arrived to our unit, yeah.
So can we just look at L1 again, please? Can you click? Just look at L1, everybody. Okay. Now, in L1, you've got pleura very blurred. You then, beneath the pleura, have these subpleural consolidations, and then you've got this large compact B line that's coming in over here. So this is kind of coalesced B lines. But I just want you to have a look next to that. Sorry.
Yeah.
So can you see this zone here, everybody? Can everybody see this?
Yes.
Say yes, everybody, please.
Yes, yeah.
Okay. So just if I give you an idea that the pleura is established here, but you've lost pleura here. You can't see the pleura at all. And you've got this area of lung, which is falling back. So just click again. So really, inspiration, it expands, expiration, it disappears. This basically is an area of consolidation with quite bright spots in between. These are static air bronchograms. Take my word for it that you also have some fluid bronchograms which are horizontal, just that you see over here. I will explain. I will show you images. These are all features of atelectasis. And really what you've got is a consolidation with atelectasis, possibly because this area of the lung is de-recruited, as you say. But what you also see over here with the snowflake sign is the pleura is quite irregular and poorly established. And again, that's a sign that you have an element of atelectasis. The lung has fallen away. So just commence image optimization. So very good depth. I can see everything all the way down. So this is up to 3.5 centimeters. Now you're using a GE venue. And the beauty of this machine is, can you see how there's no focus? The reason there's no focus is because the GE machine tends to image optimize by using cross dynamic action, which I'll talk about, and basically image optimizes each area of the lung. In fact, tissues on the GE are visible very well because of CDI. And that just means that you don't have to use focus, because the focus basically is working at every level because of this. And hence, in these machines, you won't have a focus bar. But you can see good depth. You can see the image all the way down to 3.5 centimeters. Pleura is very nicely visible. So you can see the superficial area, you can see the deep area. And because you can see the deep area, you're seeing this large consolidation right up to the bottom. So I would say your gain is beautiful. It's good. It gives me good image interpretation. It's not overpowering and too bright. The problem with using too high a gain is you tend to then exaggerate, I would say, subpleural consolidations, makes the image quite bright. It can actually make a B profile seem more obvious. If you have some A lines, they may be masks. So your gain settings are also good. I think they're very good images. And it's just to show you that this is a linear probe with a small footprint. And actually, you can make an interpretation with this without any problems. So you've seen Babin Siva use a probe. You've seen the lovely Fuad use a probe, which are completely different. What's your frequency, Fuad? Is it 10?
Yes, this 10. It is this. Yeah, this is what. Yeah.
Yeah, it's good. It's good. It's giving me all the information I need. So, any questions from the audience before we see the chest X-ray? No questions? Okay, let's have a look at the chest X-ray.
So this is the chest
Just,
X-ray. So the film is not optimum, but the patient, wasn't centralized. So the X-ray is little bit rotated to the left side.
Yeah. Does everybody agree the left looks worse than the right?
Yes.
Does anybody disagree?
But there is some rotation of the.
There is rotation, but you have a ground glass kind of an appearance on the right.
Yes.
I would say. Whereas, I mean, the left looks pretty dense. So what do we think might have happened here? Anybody? Anybody?
It might be an equal distributions of the cursor. Might be the 80 tube was deep because this 80 tube, as per team, it was at 9 at lib. But I don't know if they adjusted the level before the cursor or no. Maybe an equal distribution of the cursor.
I think that's something that would come to mind, that you have unequal distribution of cursor. Now, I just want you to focus on the right heart border here and how irregular it looks. Again, there's no focal area that looks, you've got a nice round heart border, but here it's sharp. And again, the question is this consolidation with an element of atelectasis that we were seeing? For me, it could be either. We saw the consolidation in this region. Now, that's where I would say that really what you want to do is follow this up. And ideally, this is kind of a situation where I'd be doing a comprehensive scan just to delineate better. But it just shows you the sensitivity of lung ultrasound and being able to pick up consolidation with atelectasis, which is not so easily visualized in this particular situation. The options in this particular situation are you might need to go up on pressure to recruit lung because of that, as opposed to giving this baby more surfactant, and that remains an option. So you can see how lung ultrasound kind of alters how you might want to manage a baby. Clinical correlation is key. Very good images, Fuad.
Thank you.
Any questions, Fuad, from your side?
No, just I'd like to know how to upload this one to my logbook. We can do it.
We'll do it at
Discuss
the
this
end.
at the end. Yeah. Yeah, thank you.
If you're happy to stop share, I will share my screen. Well done, Fuad. My compliments. I can open my PowerPoint. So can everybody see my screen? Am I visible and audible?
Yes.
Okay, excellent.
Yes.
So what is normal lung? Again, I want to get you familiar with the protocol we are going to use again and again and again. And as you become more experienced with being able to do lung ultrasound, a lot of you will always still want to skip to going right to what you think is abnormal. But what is absolutely crucial from our perspective, it is absolutely crucial that really when you're looking at the lung, you identify that it is lung you're looking at. Now, I want all of you to just look at me on the screen. So you have R1, R2, R3, R4, L1, L2, L3, L4. Now, just remember on the left-hand side, lower down, you actually have bowel and stomach come in. And can I just say that that can give you an A profile? Now, the only way that you're really looking at and knowing and confirming that you're looking at lung, both for the purposes of your scan description, but also medical legally, is by demonstrating the batwing sign. And a batwing sign should be visible in all your clips. So you can see here, rib, acoustic shadow of the rib with the pleura. Sliding, no sliding. So who have we got? We've got Madhusudan. Madhusudan, can you unmute and tell me whether you think they're sliding or not?
Which one is it? The left one or the right one?
Right, this one. Can you see my laser pointer?
Sliding, yeah.
I think there is sliding. Yeah.
Okay, well done. Okay, so how many of you think there's sliding? So just in the message, anybody think there's no sliding?
I think there is, well, I couldn't appreciate sliding. Like in some of the pictures I see. So I would have said no sliding.
Okay. Okay. Fair point. So just to give you a feel, I mean, it is tricky because naturally from our perspective, it's a little bit subjective. So if we're kind of in a situation where Surjit thinks it's present, we're confused. Again, follow the protocol. You've identified the batwing sign. The next step from your perspective is the pleura. You're describing its continuity, its appearance, less than 5 millimeters thin, not blurred. It looks pretty clear over here. It is continuous. There are no subpleural consolidations, and sliding is the most important second thing to identify, because if you identify sliding, by nature, what you're saying is that there's no pneumothorax there. The presence of sliding excludes a pneumothorax. Now, as we've heard, it's subjective. So what can I do to kind of confirm? Well, the first thing I can do to confirm is I can tickle the baby's foot and make him cry a little bit so that I make the baby kind of breathe a little bit faster, cry, and that will actually make the pleura move more prominently. The other thing that I might be able to do in this particular situation is get the baby to, say, for example, move a little bit, move my probe a little bit, try to get to a zone where I am completely 90 degrees, might make that better. But really what I'd be doing is I'd be doing M mode. And on M mode, if I get a seashore sign is because of shimmering of the pleura, visceral pleura moving with parietal pleura. If you look at me in the screen. So really, if you're getting a seashore sign, sliding is present. And that is a default position that you can take to try and confirm if you're confused about sliding. But the protocol is ribs, caustic shadow, batwing sign, pleura. And then after that, what you have to do is you have to describe the lung. Now, so let's see. Dr. Catty, gorgeous. What do we think about this lung in terms of, do you have A or B lines?
We have E lines there.
Beautiful. Any B lines?
I'm not sure.
Okay. Anybody? Any B lines?
Might be over here in the middle. There is a B line, possibly,
Okay.
because
Yeah.
fluid fill line.
Okay. B lines. So this is really, really important. This is a newer machine. And today we're going to talk a little bit about speckle reduction imaging, as well as I'd say CDI, dynamic kind of review of images. And the problem with newer machines is they tend to reduce artifact because the intention of every machine is to give you anatomy. But in the lung, we want more artifact. And the challenge with that is, for that reason, often what you'll find is B lines get attenuated quite often because what they're basically doing is reducing artifact. Now, for all practical purposes, there could be one B line going here, but by definition, it doesn't go all the way to the bottom and it's not dense enough. So really, this image actually, it's an adolescent with pleura. You've got parallel A lines which are equidistant, which attenuate as we move down. And clearly, at this particular point, we have no B lines. This is normal appearance of the lung for you. Okay, just like you see over here. Now I'm going to present a case because now you know what normal is. So clearly, let's have a look at what abnormal is. So we've had a baby who's preterm, 23 weeks of gestation. The baby was born, was unsteroided, was delivered by normal vaginal delivery after having kind of been having bulging membranes for a bit. There is also a history that she might have had early prolonged rupture of membranes. And pretty much this baby was intubated, has had 3 doses of surfactant, and remained in quite high oxygen settings over the first 2 weeks of life, to the point where on day 12, this baby kind of went into a significant amount of oxygen, 70, 80%, was struggling to saturate. So eventually got paralyzed, sedated, screened and started on antibiotics. And on day 14, 3 o'clock in the morning, we got a call because my colleague had to oscillate the baby because the baby wasn't saturating. The baby was in 100% FiO2, desaturating down to 70%. I think his feeling was that we try and recruit the baby. Because the baby had been paralyzed for 48 hours, the baby was quite edematous, and we'll see a lot of soft tissue in the images. So kind of translumination in this extremely preterm baby being so edematous wasn't really very helpful. What he was able to confirm is that the tube was in the right place because he had good bounce. Certainly on the ventilator before he went to the oscillator, he had good flow loops, and they used end-tidal CO2 to kind of confirm that the tube was in the right place. There was good chest wall movement. So clearly from the dope mnemonic, there are a few things that could be happening to this baby. I mean, clearly we might have lungs that are not very well recruited or have de-recruited. We might have a baby who's got problems with a pneumothorax acutely. We might have a situation where this baby actually doesn't have a pneumothorax but has maybe evolving pulmonary hypertension. And we can get an X-ray, which will take about 20 minutes for the person to arrive. Can you imagine the amount of handling in a paralyzed, sedated baby to lift this baby, put the X-ray plate underneath the baby? Clearly, if this baby has a pneumothorax, which is my gut feeling quite significant if he's acutely desaturating and 100% oxygen, you really want to kind of do things relatively quickly. Now, this is the image, and we're going to nominate somebody. So Surjit, Dr. Surjit?
Yes.
So I would like you to kind of describe the image. So I'm just going to play the image. So can you see a batwing sign?
Yes, I can see. I can see, in fact, 4 ribs, 4 to 5 ribs.
Yeah. So what you've got is a still image on the left. Now,
Okay.
I'm using a linear probe in a GE machine. My frequency at this particular point is 12. So just in terms of seeing the batwing sign, this is L1, and I can see 1, 2, 3, 4, 5 ribs. Now, if you say that 12 ribs, that's a decent L1. It's virtually the whole of the left side of the lung. And so with the batwing sign, what are you going to describe next?
I can see the batwing sign, and then let's go to the pleura.
Yeah.
And the pleura looks irregular, discontinuous. and disrupted, and lung sliding, pleural sliding is present. And then I can see subpleural consolidations. There are like snowflake signs in certain areas, and there are increased B lines. In fact, we can say compact B lines, and I can't see A lines. Hardly one or two A lines are visible.
Yeah, maybe
So,
one over here with the eye of faith. So, I mean, you've basically got, I mean, I'd say you're right, an element of subpleural consolidations throughout snowflake sign, but I mean, there's virtually no A lines. This is a complete whiteout. This is AIS. So the compact B lines have merged together, and you've basically got what is whiteout lung AIS. Now, by definition, and I'm going to go through this, I'm just giving you a flavor of it. To define AIS, you should have a whiteout in more than 3 regions. So that would be L1, L2, L3, L4, L5, L6. So 3 regions kind of demonstrating this by definition of Dr. Leo would be a whiteout. If it's less than 3 regions and it was only this region, then what we'd be calling this is alveolar interstitial syndrome. And what it reflects is there's a lot of interstitial fluid with subpleural consolidations. Now, for a 14-day-old baby, would you call this RDS, Dr. Surjit?
no, Dr. Alok. No.
So you have to clinically correlate, and that's crucial because when you clinically correlate in this particular situation, really, you're not going to make a diagnosis of. Now, just looking at L1, we know air rises anteriorly. Do you think there's a pneumothorax over here?
No, there's no pneumothorax.
Because you don't have an A line and you have pleural sliding. So that excludes a pneumothorax, at least in L1. Let's look at L2 and L3. Sorry, guys, could we just mute ourselves? I'm so sorry. Yeah, my apologies. Yeah, go for it, Surjit.
Yeah, in L2, we can see the batwing sign, and the acoustic shadows are also in between visible.
Yep.
And the pleura is again disrupted and discontinuous, and I can see subpleural consolidation in few areas.
Yep.
And there are B lines which are lesser than the previous region, but there are significant B lines.
Yep. So what I'd like everybody to have a look at is what is classically a consolidation. So you remember I said a consolidation always appears from the pleural line. So you have an irregular pleural line over here, very blurred, subpleural consolidations. But here you lose your pleural line completely. And really, from our perspective, what you've got is quite a large subpleural consolidation that you see over here. And that has static air bronchograms, these bright spots that you see over here. Now that would kind of be an area of atelectasis. This is L3. So again, you've described it very well. Now, with the eye of faith, L1 is completely white, but you have some A lines over here. So this is a little bit better aerated, L2 and L3. Now, classically, what did we say about RDS? It's uniform. It's uniform whiteout. It's uniform subpleural consolidations. Here, L1 is very poorly aerated. L2, L3 are well aerated. So, I mean, these are lungs that seem chronic. You know, the question is there an element of better aeration lower down and laterally? And it'll be interesting when we see the chest X-ray. But let's go to L4. So what do we think?
Yeah, in L4, we can see the batwing sign, and the pleura here is again disrupted and discontinuous. Lung sliding is present. The subpleural consolidation is there, and there are increased polarized B lines.
Yep. So again, what I'd say is that when this baby expires, can you see how the pleura thins out? And when he inspires, which is the ventilator going in, the pleura becomes established. So there's an element of lung falling back, retraction, subpleural consolidations. And what I'd say is a little bit of microatelectasis that's happening there, and we'll talk about it. But I mean, to give you an idea of what clear pleural sliding looks like, that's clear pleural sliding for you. On the right, can everybody see that? Okay. Now over here, it's tricky. You know, the pleural sliding is really slow. But what you can see is, can you see the compact B lines move? And that is a marker of sliding. But also these small subpleural consolidations are moving laterally as well. And that can be an indirect marker of sliding. So actually, if you're confused, then that is something that you can look at. There's one other thing that's happening that I'm not going to talk about today. We can talk about it on a later date. But let's look at R1 to R3. So do you want to talk about that, Dr. Surjeet?
Yes, Dr. Alok. I can see the batwing sign. And is there some pleural effusion? I'm not sure if there is a pleural effusion there. And the pleural line is again disrupted, discontinuous, irregular. Lung sliding is present, and subpleural consolidation. In one area, it is quite significant. This area, and there is, compact B lines seen.
Okay. So that's great. So just to give you an idea over here, so this is R1 to R3. So we're progressing backwards from front to back. And at least you've got established pleura in R1. In R2, you've got an element of pleura that's established, and then the lung tends to fall away in this region over here. That is basically, could be a mnemonic kind of a fractal sign, or it could be a little bit of atelectasis. And I'm not going to go into how you diagnose it today. But really, when you go to R3, there is no pleural line established, and the lung has basically fallen away completely. And you've got complete whiteout. Okay? Now, if you remember L2 and L3, you had some aeration there. So just with the eye of faith, do you think the right is worse or the left is worse?
Right is worse.
Okay. And if you wanted, from your perspective, to help this baby, what would you be thinking of?
Well, the lungs have to be recruited, and I usually, if I go for chest physiotherapy also when the baby is on ventilator, or even if on non-invasive and there is such huge consolidations or atelectasis.
So going up on the map in an oscillated baby would be an option?
Yeah, yes, sir. It's oscillated.
So I just want to show you again, this is it's the back of the lung. It's L kind of 5-6, which I'm doing through the posterior axillary line. That basically, sorry, R, my apologies, is liver. The diaphragm's not very visible because we're using a low frequency, but you have no established pleural line, and this is basically static air bronchograms with a complete whiteout. This is lung that we can recruit. So what I've been able to establish at this particular point is that I don't have a pneumothorax. I do have lung that's really atelectatic, especially the posterior regions, and would be amenable to recruitment. And I definitely think that the right is worse than the left. So let's have a look at the chest x-ray and see what we find. So really consolidated lung. Again, the left lung slightly better aerated as compared to the right lung, which shows quite significant amounts of, I would say, consolidation. Now, the atelectasis, and I haven't shown you R5 and R6 well. I haven't shown you L5 and L6, but L5 and L6 had quite severe atelectasis as well. So really, this is an X-ray that I get after 30 minutes. But for me, what I want to exclude is a pneumothorax, which I have. I've put the maps up, and actually putting the maps up on this baby from 16 to 20 really helped us recruit lung in this particular situation. So it's just an example of how you can, from your perspective, use lung ultrasound to help guide your management. Any questions about that?
No, thank you.
Will you tell about the dynamic and static
I'm going to talk
bronchograms
about
later?
it now. I will talk about that later. I want everybody to forget about that today. We'll talk about that. Yeah. I mean, just to give you guys an idea. So bronchograms basically reflect air coming in and out of the lungs. So as an RDS, when you have an X-ray, you have air bronchograms that are coming in lungs that basically are consolidated. This is the way they look. This is a classical tissue sign, and you've got these snake-like appearances of basically what is air moving in and out. Now that's because your lung is consolidated, full of fluid and exudate. So you have air going into the exudate. And air basically acts as a very good reflector. Now, because of that, you get this bright appearance of air. These are dynamic bronchograms and they're seen in pneumonia. But today I want you to forget about them. Today, what we want to concentrate on is image optimization. And really, what is quite crucial, I think from my perspective, is the fact that when we talk about image optimization, every machine
This meeting is being recorded.
Sorry, my apologies. Just going back to the presentation, can you still see my screen?
Yes.
Okay, excellent. So there are a few things that we can do to try and optimize our images. We can play with frequency, we can play with gain. For machines that have focus or more than one level of focus, we can adjust that. For newer machines, we have speckle reduction, which is quite important. You don't want to increase it to a point where it removes all your artifact, because then you're going to really struggle to get B lines and a lot of the A line artifacts visible. But really what you want to do is keep it at a level where it doesn't make the image, in particular the pleura and I would say the tissue images, bright to the point where they basically then obscure your ability to interpret artifact. And then what I talked about is dynamic range, which is something that allows us to be able to visualize tissue better. Now, really, we've talked in the last class about containment, and containment is crucial. And the reason I'm emphasizing this again is because your images and the quality of your images, you can play with the machine as much as you want, but if you've got a baby that's moving all around, or you're trying to image the lower part of the lateral region with clothes, you're just not going to get good images because you're not going to get good contact. And if you do not have good contact, altering the actual machine is not going to make any difference at all. So it is absolutely crucial that you consider and alter images only if you're absolutely certain that you kind of, from your perspective, have got a baby that you can control. Because if you have a baby like this who's out of control, then really you're not going to be able to get good images. So you need to be able to use dummies. So crows, keep the baby relatively still. Like this baby's all over the place. Good luck, you know. Again, swaddling. So can you see how the arm is kept here? Now, can I just say that if you're looking for your R3 and L3 images in the axilla, you need to have the arm abducted beyond. You're not going to be able to get good alignment in the axilla. And often what happens is that really compromises your image quality. So just get the nurses to abduct the arm up so that you can actually get the probe, as you see over here, into the axilla, especially for your R3 and L3 images. The harder you press, the more the baby will fight and you're asking for trouble. So, clearly you can see this baby struggling. He hates it. The probe should lie on the baby. It should not press. You need good contact. You don't have to press hard for that. The harder you press, the more it's painful for the baby. It's an unpleasant kind of an experience. So again, what I would say is just keep the probe in good contact. It's important that somebody's keeping an eye on the baby. But what you really, if you're being able to iron out and keep your baby still contained, comfortable, and you have good probe technique, then really the next step from your perspective is how you then use the machine to optimize your images. Now, this is a GE Vivid. It's a beautiful machine. It's one of the best machines I've ever worked with for doing lung, heart. I also love the Philips, and I mean the Siemens, and some of the other machines that are being developed these days are absolutely amazing. So what I'd say is that's good. But if you have a machine that's old, that's not bad, because actually what you will be able to see is a lot of people will use old machines in this course, will show us images, which we will be perfectly able to interpret as long as we understand the limitations. Now, for any machine, just to go through a little bit of knobology for you, that's the main button to switch it on. Most machines need to be connected to a power source, but really you'll have kind of a board, and the board will have a number of buttons with what is a trackball to be able to move your cursor. Now, the main things that we want to kind of play with at this particular point are our depth, our frequency, uh, and really to try and optimize our image, there are functions. So there is gain compensation, or what we call as auto gain in some machines. Now, to kind of get your gain settings right, if you have an auto gain function, you put probe gel, and this is very crucial. Now, for a lung ultrasound, it's really important that you have gel that's uniformly applied throughout. So if you have gel over here and no gel over here, the way you interpret images and image quality will not be great. But more importantly, if you lose contact, then really your interpretation will be affected. So you want to uniformly apply gel, and really you want to go to either a preset setting or set your settings, where once you apply this to the baby with the gel, you can then press auto gain, which we call TGC in our machine over here, and that will automatically try and compensate your gain settings. If you lose contact or you find the gain settings are very bright because the machine is having a thing, you can press it again. And especially in the GE, it usually takes 2 presses for the machine to actually delineate what the best gain is for that particular setting. In terms of probes, classically, the probes that I like using the best are the linear probe. And this is a linear probe which gives me a frequency technically up to 12, actually, though it says 11L. It's beautiful. For extremely preterm babies, I get the whole of the chest, R1, R2, R3, R4, L1, L2, L3, L4 in one view. The other probe, which gives you a higher frequency, which is good for extremely preterm babies because you want to see the superficial areas of the lung concentrate on the pleura, is the hockey stick, which some of you have shown me. But really, it has a frequency that ranges from 8 to 18. And I usually start with a frequency of 12 and build the frequency up to try and optimize my image to see the superficial areas. If you want to get between ribs, you want to kind of see a very superficial area of lung, you can technically use the sector probes as well. I tend not to. Nadia will cover that a little bit more. Just in terms of keeping your probes, can I just say that if you drop your probes, they hit the floor, the kind of quartz crystals inside them get damaged. And I kid you not, it's really frustrating when that happens because your image then quality, it suffers and there's no way that you can optimize it. Few things that we will be using in our machines are M mode, as I kind of described, see the seashore and the barcode sign. But the other thing is when we're trying to differentiate atelectasis from consolidation, or when we're trying to look at pneumonia where you'll have increased blood supply to that region, or a fractal sign, you'll be using color Doppler. And there's certain other situations where you'll be using it as well. That's there in every machine. So you start your machine, you select your probe. Now, how do you select your probe? If your probes are all connected, as I said, I like using a linear probe. And my linear probe will basically, when I click on probe, come up with this configuration. And I have preset settings where I've set the lung term small part setting. It's a preset kind of a setup, which basically gives me and starts with a frequency of 9 and allows me to reduce or increase the frequency as I wish with a depth that is 4 centimeters already set, and basically settings that I will subsequently explain to you to kind of give me what I would say is an optimized image, but I won't hesitate to play with it. For the preterms, we kind of default to a frequency of 12 and a depth of about, I would say, 3 to 3.5 centimeters, which is good enough, in my opinion, to be able to give you a good breadth. How do I define that? For babies under 32 weeks, under 1500 grams, I'd use the preterms kind of probe. For babies bigger than that, I won't hesitate to use the term probe. And I can interchange and play with the settings of using the probe with the term or the preterm small part setting to try and get the image quality that I actually want. Entering patient details, quite crucial, very important. Now, for most machines, what we have is the ability to kind of enter and open the patient, but add exams if we feel that the image quality is poor. But when you've set your probe and it's not in contact, really what is important is that you look on your screen, either the right or left-hand side. Can you all see this? This is quite crucial. Please say yes. Can you see my cursor? Can somebody say yes?
Yes.
Yes, yes.
Yeah, we can.
What is very important is that's going to give you the frequency you're using. And I have defaulted in this baby to using what is basically my hockey stick, L18 to 18. Now, if I default to the vascular setting, it automatically defaults to a frequency of 9. It doesn't give me any auto gain. at this particular point. I'd have to press the auto gain button, but it defaults to a dynamic range. And it gives us a few things like the depth, which is 1 centimeter. Now, clearly, this is the vascular small part setting. This is not great for looking at the lung because it's only 1 centimeter. But if I want to see superficial blood vessels, this is fantastic. And I'm just giving you a flavor that if you don't already have a preset configuration on your machines, you can call your ticks, develop those settings based on what we discuss in this course. And ideally, what I would say is you need to have 2 presets, one for the term and one for the preterm baby. You also need to be able to use your probe raw, which kind of means that if I find that this preset setting is not working for me, I would normally go back to my machine. And I'm just going to take you back. So I basically go back to my machine and it has a button for frequency, which is over here. And I press on that and that basically lets me alter frequency. But really what I can also do is I can alter the depth by clicking the depth button. Sorry. I can show you the depth button. I hope I've got it. So that is my depth button, and I can increase and decrease depth to kind of focus to the region that I'm really interested in. But more importantly, if I'm really struggling, I can play with the frequency. And you know that increasing frequency allows you to view more superficial areas of the lung. And in kind of decreasing frequency means that you can concentrate on the deeper areas. So really, you do have to play with your buttons, even if you have presets, to try and optimize your image. So I'm just going to show you a video of how I'm doing it. Now, there are a few things that modern machines have that can enhance your image further. And one of them, and again, I would say, please get into your text to come and help you set up for a lung preset. I have edge enhance, and really I like using edge enhance. I like to enhance up to 2 because actually it gives me much more crisp pleura and A-lines. The other thing that I play with is the dynamic range, especially if I'm trying to look at a consolidation in tissue. So by increasing dynamic range, what is actually happening? So you need to look at me, please, everybody. So when the ultrasound probe is throwing ultrasound waves that's hitting tissue, these waves are basically interacting with the tissue. Now, as I said, the pleura is a reflector and is quite bright. So really, because of that, underlying tissue and the interaction with tissue basically gets attenuated. Now, by increasing dynamic range, what you're doing is you're increasing the ability of these ultrasound waves to penetrate beyond pleura. Now, naturally, if the ultrasound waves can penetrate beyond pleura, they're going to interact with deeper tissue better, and you're going to get better depth analysis. You're going to get better interpretation of the tissue and artifact that's deeper. So if I'm looking at a consolidation, in particular a deep consolidation, and I'm kind of not getting good pleura, and I'm trying to debate, is this a consolidation or is this artifact? I might actually want to increase my dynamic range if it's something that's deeper, but I might want to decrease my dynamic range if I'm trying to interrogate just the pleural area. Alternatively, I might just want to increase my frequency. So there are multiple ways in which you can kind of help yourself. But there's one more thing that is very important. This is because I want to look deep. Now, for some people, they like using sharp mode. Some people like using, I know for a fact that Nadia loves using soft mode. And it just kind of, from our perspective, is your choice. I like using sharp mode because it tends to give me a much more crisp pleura. But this is something that I think is really important. Now, in your guideline, in the guideline that is basically there as described by Dr. Zhu, there is, in the old guideline, a kind of use of harmonics, which is very confusing. Should we take harmonics out or should we keep harmonics in? Now, for a modern machine like the GE, for, I would say, the Sonicade, the modern Philips, it's not an issue because actually harmonics are not a big issue. You don't have to adjust harmonics at all. Just use your machine as is. But what you might have to do is work with speckle reduction. Now, what is speckling? So I just want to show you an image. Yeah, we'll come to that. So can you all see the image that I've clicked on the left-hand side?
Yes.
What do we think about gain here?
It's high gain.
Okay.
Gain looks
Sorry?
Gain looks more. It's very bright.
Very bright. Okay, so great. So this looks really bright. So it's exaggerating my A lines in a big way. Now, clearly, I want to also concentrate on sliding. I can see all the way down. Now, if I wanted to kind of get good gain, I could press the auto gain function in my machine, which is basically, and most modern day machines will have it. So that is TGC, total gain compensation, that I could press over here, which basically auto gains and selects my gain. Alternatively, I've got a gain button over here, which basically allows me to reduce the gain spontaneously. So really, you could use either, but the risk of having very bright images, you tend to exaggerate your artifact, and B lines that might not normally reach the bottom might look very, very prominent. Now, over here, what you can see is the batwing sign. You can see pleura, and you can see A lines all the way to the bottom. Now, this is the same image, but with auto gain. And can you see how much better this looks in terms of A lines?
Yes.
So this is basically auto gain, bringing things back. The problem that I have over here as well is I have very high speckling. Now, what is speckling? Speckling basically means that when the sound waves interact with pleura and lung tissue, they tend to cause blurring or speckling of this tissue to appear incredibly bright. And that's reflected by the fact that you've got these really thick A lines that you see over here, and then these really thin ones over here. So you have a lot of speckling over here. Now, by increasing speckle reduction, I just get a more uniform picture. And this is really my point of interest. So there's no pleural sliding. So, okay, protocol, batwing sign, seen visibly. There's pleura over here, and take my word for it, there's no pleural sliding in this region. A lines all the way to the bottom and a classic barcode sign. This is a pneumothorax. You've also got a truck sign. You can see these areas of reflected ribs over here. So if I've reduced my speckle reduction, I get a much better image, which is much better to interpret. I mean, you can make the diagnosis over here as well because the pleura looks so bright. I'm just really confused about whether there's sliding or not. If I'm confused about whether there's sliding, because this is the same image, I'm going to use M mode and see the barcode sign, the classic barcode sign that you see over here. But where does the dynamic range come into it? So this is dynamic range for us. And really, what I want to see is I want to see this tissue. I want to see the sound waves interact better with this tissue. And this is a depth of about 4 centimeters. So what I've done is I've just increased my dynamic range. Now, for all of you, what I need you to do is I need you over the next 10 days to play with your machines while you're getting your images to try and get this. And this is just an example of dynamic range. So here we're using a low dynamic range. Because we're using a low dynamic range, our image basically is quite blurred. I would say it's quite grainy. Whereas here I'm using a higher dynamic range, which kind of means that we're interacting with tissue better. So this is really giving me just a much better tissue image. So you can play with all these parameters, but what about frequency? So let's say I want to see the depth of the lung. I want to see the deeper area. So at this particular point, so can you see this image on the left?
Yes.
Okay, Dr. Ashraf, would you like to describe this image?
This is an M mode imaging. The depth about 3 to 4 centimeter.
Yeah.
There is, I don't see the pleura clearly it is sliding or not. But this is a smooth pleural line. It's normal pleural line. في line بس the image more bright. الام مود في sand beach appearance.
Okay, all the way through. So this is Sandy Beach. Okay.
Yeah.
Keep watching. And now you have a barcode sign. Can you see the difference?
Yeah, yes.
Sandy Beach.
Yeah.
I've lost contact. Now
Yes.
I'm basically starting to evolve. I think the point I'm trying to make is I want depth over here. And for depth, what I have done is I've dropped the frequency so that I can actually see A lines all the way to the bottom. And actually, they don't attenuate as much. So I've used
Yes.
frequency with depth to actually image optimize to see this pneumothorax. And that's the barcode sign that you're getting over here. So I'm just going to show you the other image. Same image. Okay. Good or bad? Can you see the deeper areas nicely or poorly?
Poorly.
Yeah.
I think so.
At the moment, I'm using a higher frequency. I'm getting a very good barcode sign. But again, the challenge here is I'm just using a lower dynamic range, which means the image quality is not great. So by increasing the dynamic range and actually just dropping the frequency a little bit, I get a much better image, which is what I'm doing over here. So I start my image optimization now. And what you'll find is as I drop my frequency, the image will get better. Now, sorry, my apologies. Can you see the difference in the image quality?
Yes,
So
yes.
again, it's about
Left side barcode and right side sandwich.
frequency we've talked about, image optimization. So just remember, for term babies, we're talking about a frequency of about 9. Smaller babies will need a high frequency, 12. You can use up to 15. You're going to see the most superficial areas. I think the impact of the probe is quite crucial because, again, can you see the differences between using a long linear probe? You're going to define more anatomy, get more rib spaces, as opposed to a convex probe, which really, because of the curvilinear nature of the sound waves coming through, doesn't really give you very good depth penetration either, because the sound waves are not moving at 90 degrees and coming back to you. That being said, if you had to image optimize for this convex probe, what I would try to do is there's a width parameter that you can reduce to basically reduce this to a narrower window. And because you'll have a narrower window, the sound waves will be concentrated more. And because of that, you'll get better depth, more localized, and a better image in this area by actually reducing the width of the window. You'll be able to see pleura, but pleural line will be visible in a much smaller context, and it'll be more difficult to see sliding. So again, that's the importance of understanding the limitations. This is kind of, in a nutshell, a little bit of image optimization for everybody today. Just to summarize, again, I'm just going to take you through it again. So really, with your machine, what you're doing is switching it on, connecting it to a power source. Once you connected it to a power source, really what you're going to do is select your probe, apply gel uniformly over it. So just remember the infection control that we discussed last time. You're then going to select your kind of probe preset, which is small parts. Could be a preset for a preterm or a term baby. Once you put the probe on the relevant anatomical area, and our protocol says we always start with the area of interest. So if I think the baby has a right-sided pneumothorax, and you spend time doing the left and the right side is then tensioning, it's better to always start with your area of interest. So I examine the baby before I start. If I've got reduced right-sided air entry and transluminate on the right side, I'm going to go with the right side. If I have reduced right-sided air entry with an endotracheal tube in a 3-kilo baby that's 12 centimeters, really the question is whether it's down the right main bronchus and this baby has a right collapse. So again, I'm going to start my lung ultrasound with the point of interest, which is the right side in that situation. But once I've got my probe on, if you have an auto gain function, you can press that. If you don't have an auto gain function, you can increase or decrease the gain by altering it by the gain button. You will usually preset your depth to 4 to 5 centimeters for a term baby, 3.5 centimeters for a preterm baby. If not, you can adjust your depth. For those of you who have focus or multiple focus, one focus should always be at the pleural line and one focus relatively deep. If you have a single focus, you might have to change the focus to actually visualize superficial or deep structures depending on your interest point. But more importantly, once you've adjusted these settings, really what you're then going to do is go into what I would say is your other settings. And really your other settings would be, if you have them in your machine. So I've just gone for a preset setting. Sorry, my apologies. So if you have edge enhance, you can set it to a range. So different machines will give you different ways of doing that. They might give you a button which gives you 5 levels. They might give you a percentage, and it's kind of working on it to give you the best image. Again, depending on your depth and tissue and the quality of the image, you can play with dynamic range. You want to keep speckle reduction to a point where you're reducing significant speckling, but you don't want to keep it so high that you take away the artifact completely, because it causes problems with attenuation. It's up to you whether you want to use the soft or sharp modes. There's not much role in my mind for persistence, and I'm not going to go into compound frames today. Any questions?
Dr. Alok, do we have this edge enhancement and speckle reduction in all the machines?
No, we
Or
don't.
can we
Old
opt for it?
machines, no, old machines don't have them. And my advice is, whatever machine you're using, get used to using it. You will be able to image interpret and mental model and make correct diagnosis, irrespective of the probe you use, as long as you understand the limitations. It might be that your machine and the probe that you're using is a convex probe. So again, what I would do is, rather than try and fiddle with the settings, the question is, can you reduce the width, improve the penetration of, I would say, sound waves to give you a better image? Can you play with the frequency in that to increase or decrease it? Now, naturally, if you're using a convex probe, which is kind of 8 to 6, really using the frequency of 8 is going to be the highest frequency that you can use if it's the cranial ultrasound probe. But we will talk about, and I will show you images of how to interpret with that. I would say just use your machine. For those of you who are going to show us images, can I just ask you to take a photograph of your machine, its board, and the settings, and WhatsApp me individually. Don't WhatsApp me on the group. It'll go crazy. I will get confused. It's easier for me to see them individually and then to kind of give you advice. But call your technicians in to try and image optimize. Madhusudan, you have your hand raised.
Yes, hello. I just wanted to know some of the settings, if we adjust, we might be contradicting. That's what I assume. Like the one in the dynamic range, if we keep it increased, I presume it also smoothens out the image, like it decreases the
Very good.
contrast. Whereas if we press the sharp mode, I assume it would increase the contrast, right?
Completely. You're absolutely right. So there can be interplay of these different factors. But again, I am trying to optimize my image in context of what I'm seeing. So really what I'd say is, to give you an example, machine is dying today because of too many videos.
Recording in progress.
So really, just to give you an example over here, my focus over here is the deeper tissue and atelectasis, less the pleural line. So if I want to image optimize to see the deeper tissue, that's when I'm going to increase my dynamic range. But actually, if I use my protocol would have started with the batwing sign on the pleura. So I'm going to make those changes only when I want to visualize deeper tissue and its architecture, not before. So if you use your protocol in a proper way, then really what you'd be doing is starting with the batwing sign, keeping your focus at the level of the pleura, adjusting your frequency to basically focus on the superficial area to get superficial anatomy, And really now I'm looking at lung atelectasis. If I have dropout in this region because it's 5 centimeters and I'm using a high frequency with focus at this region, then to optimize the deeper structures, I could reduce my frequency. I can technically, if I'm looking at a tissue kind of area, increase my dynamic range, but I wouldn't necessarily do that at the start. So image optimization itself is a dynamic process. And with time, you'll just get better with your machine at being able to do it. Does that help your question?
Yeah, absolutely. Thank you so much. Yeah, I'm trying to get the optimal image, but I'm just getting errors because maybe my settings are not appropriate. And I'm not sure actually what are the reject function should be, whether it should be 0 or 1 or 2, or how much should be the persistence.
Can we not talk about this today? Just
Oh yeah, okay.
because my gut feeling at the moment is that'll be playing with too much. I just want you to get these things. If we can use focus, frequency, and depth for the first 2 weeks of our training to try and get the best images that we can, trust me. I mean, if you see Dr. Bhavin Seva's images and you see Fuad's images, they're absolutely beautiful to interpret. I have no problems with them. Small tweaks here or there. And we can talk about that when you show your images. Any other questions? Because I don't want to kill you all. It's 9:30. Yeah.
What is the best way to clean the probe, to disinfect?
So, what do you use locally? As long as you're not using sulfuric acid. Yeah, I'm just kidding. I mean, what I'd say is that we use Clinell wipes, which is something that we've used in the UK. If you're really obsessive about it, then Crystal comes up with an ultrasound cleaning solution, which basically is a 3-stage solution which kills everything, including fungus and spores as well as viruses. It's not cheap. It's quite expensive. You'll get about 50 cleans from 3 bottles, so which come kind of as sachets. So you have a bottle with foam in it. So I'm happy to WhatsApp you all the cleaning solutions. If you have nothing, I would say the important thing from your perspective is not using something that's going to be corrosive, not using something that's going to be damaging. If you start using 100% alcohol on it, which is near a flammable substance, if you smoke and do ultrasounds and you're putting 100% alcohol on it, you're going to ask for trouble. So Clinell, the alcohol Clinell wipes at 2% and 70% chlorhexidine, that'd be absolutely fine to use. Any other questions?
I am using Vivid IQ 5.
It's a lovely machine.
I'm just selected the linear probe L2, L12 and the small part. Everything coming, it is okay.
Perfect.
If I needed any change, I just by touch, I can manage.
Yep. And you might have a preset small parts. So to start off with, I didn't know how to do it, and I would just use vascular, which used to default to 2 centimeters. Now all I do is increase my depth. And because it defaulted to a frequency of about 12, I could change the frequency as well. So I would say play with your machines, and the next 2 weeks is an opportunity for us to try and help you get better images using your local machines. Okay.
Yeah.
Ashraf, I'm just conscious you weren't able to present today, so you'll be first for the next session. Just remember.
I am sorry because I am my electricity is off in my area, so I joined later. Okay,
No
I am
problem.
ready anytime. Yeah.
No, absolutely. I'm sure.
I am ready anytime.
Sunday's session is very important. It's the first thing we're going to cover. What we call is lines and signs. We're going to cover everything normal, but all the different signs that are described in the literature. And I'll be sending you an article to read. So please try not to miss that if you can. If you can't make it, it'll be on recorded. Okay. Thank you, everyone.
Okay.
God bless you.
Thank you.
Thank you.
Have a nice day. And well done.
Have a nice weekend. Have a nice weekend.
Thank you, Alok.
Thank you.
Have a good weekend, everyone.
Thank you.
Thank you. Goodbye.